So topic we are going to discuss today is Papilledema from the 9th edition of Kanski. It's chapter number 19 and from the Neuro-ophthalmology. Papilledema is swelling of the optic nerve head, secondary to raised intracranial pressure. Important point. Disc swelling and disc edema are non-specific terms that include papilledema, but also a disc swollen from other causes. All patients with papilledema should be suspected of harboring an intracranial mass. Not all patients with raised intracranial pressure will develop disc swelling. Causes of swollen disc will be discussed later. All patients should undergo urgent neuroradiological investigations to exclude intracranial pathology as it can be lethal, and it also can lead to great morbidity and optic atrophy in the end. Causes other than papilledema of disc elevation include accelerated hypertension, anterior optic nerve uh, neuropathy, which can be ischemic, inflammatory, infiltrative, compressive due to orbital disease. It can be pseudo-papilledema due to disc drusen's, tilted optic disc, peripheral myelinated nerve fibers, crowded disc in case of hypermetropia. It can also occur in mitochondrial optic neuropathies like in Leber hereditary optic neuropathy or methanol poisoning. It can also occur in cases of intraocular diseases like central retinal vein occlusion, uveitis, posterior scleritis, and hypotony. All of these causes are very important and should be cracked. Next comes the circulation of CSF or cerebrospinal fluid, which is formed by the choroidal plexus in the ventricles of the brain. Choroidal plexus leaves the lateral ventricle and it enters the third ventricle through the foramen of Monro. From the third ventricle, it flows through the Sylvian aqueduct to the fourth ventricle. And from the fourth ventricle, the CSF passes through the foramen of Luschka and Magendie to enter the subarachnoid space, flowing around the spinal cord and bathing the cerebral hemispheres. Absorption is into the cerebral venous system through the arachnoid villi. Normal CSF pressure on lumbar puncture, not upright, is 10 to 18 centimeter of water in adults. And we should remember this and have a picture of this on our mind, like this one, which shows the lateral ventricle and to the foramen of Monro and to the third ventricle, passage of CSF to the fourth ventricle, through the aqueduct of Sylvian and to the foramen of Luschka and Magendie. Now, causes are very important. Most importantly, idiopathic intracranial hypertension. 1. Number 2, obstruction of the ventricular system by congenital or acquired lesions. Number 3, space occupying intracranial lesion including hemorrhage. Number 4, impairment of CSF absorption due to meningitis, subarachnoid hemorrhage or trauma. 4. Number 5, cerebral venous sinus thrombosis. 6 is cerebral edema from blunt head trauma. 7 is severe systemic hypertension. And 8 is hypersecretion of cerebrospinal fluid by a choroidal plexus tumor. and that is the rarest of them all. These 8 causes, the most important one is idiopathic. CT scan showing subarachnoid hemorrhage in the posterior region. Now, symptoms include, most importantly, headache, characteristically occurring early in the morning and may wake the patient from sleep. Although less commonly, they can occur at any time of the day. The pain may be generalized, it can be localized, and it may intensify with head movement, bending, or coughing. They tend to get progressively worse over time. Very rarely, headaches may be absent. Number 2 is nausea, which is often episodic and with associated projectile vomiting, very characteristic. May occur as an isolated feature and it may also precede the onset of headaches. Deterioration of consciousness as severity increases, initially with drowsiness and somnolence. A dramatic deterioration in the level of consciousness may be indicative of brainstem distortion and requires immediate attention. Visual symptoms are commonly absent in mild or early raised intracranial pressure. Transient visual obscuration lasting up to 30 seconds in one or both eyes are frequent in established papilledema and are sometimes precipitated by bending, coughing, or Valsalva's maneuver. Disc swelling due to other causes is usually associated with more persistent visual impairment. Now, horizontal diplopia due to sixth nerve palsy caused by stretching of one or both abducens nerve over the petrous tip is a false localizing sign. Vision is generally normal or minimally reduced. Significant reduction is late feature and it is in conjunction with the secondary optic atrophy. Neurological examination should be performed, of course, that is ideal. Uh, Next would be uh, investigations, but before that, I would like to show this diagram where you can see abducens nerve over the petrous tip and dilated ventricles and how raised intracranial pressure affects them, uh, causing pressure on the abducens nerve resulting in palsy or paresis. The most important investigation is B scan ultrasonography, and it can be used to aid in distinguishing between papilledema and other causes of swollen or apparently swollen optic disc, pseudo papilledema, with 80 to 90% sensitivity and specificity. By measuring the external diameter of the optic nerve sheath disc, the optic nerve sheath's diameter, which is substantially distended, 5 to 5.7 millimeters or greater, at 3 millimeter behind the globe. The nerve must be scanned axially for the measurement to be accurate, and there is a degree of operator dependence. In contrast to spontaneous venous pulsations, optic nerve sheath diameter does not normalize with short-term intracranial pressure fluctuation. Uh, the crescent sign, which I'll show you, refers to an equilucent area in the anterior uh, intraocular nerve, thought to represent increased separation of the nerve and its sheath. Lateral gaze, that is a 30-degree test, commonly leads to 10% reduction in diameter on A scan, measured in the presence of excess fluid, but not if normal or if increased optic nerve sheath diameter is due to infiltration. Fluid-related ONSD can also be caused by other pathology such as inflammation and trauma. MRI to exclude space-occupying lesion or enlarged ventricles MRI can also be used to measure an ST. Average normal diameter approximately 5.5 plus minus 1 millimeter on MRI. In certain cases, vascular imaging such as venography may be performed to rule out cerebral venous sinus thrombosis. Lumbar puncture must not be carried out until imaging has excluded a space-occupying lesion that might cause downward herniation of intracranial contents towards the LP-induced low-pressure area. Clotting abnormality, including therapeutic anticoagulation, is also a contraindication unless reversed prior to doing the lumbar puncture. Uh, in the end, I would like to show you the crescent sign in the second picture, the B picture. There is the equilucent area